I want to introduce Aditi Shah. Is that how you say your first name, Aditi?
Yeah, it is. Yes, it is. Yeah.
Okay, Aditi
Perfect.
Shah.
Yes. Yeah.
She is an assist or a clinical assistant professor at Division of Respirology, University of BC. She also works out of BCH. She's a medical advisor for the Provincial Respiratory Outreach Program, a PROP program it's called, which I'm actually a member of. And she's basically an expert on respiration and respiratory incidents that can happen and how to avoid them or
Mhm.
what to do about them. So with that, I will actually give it to Aditi to get started.
Okay, perfect. Thank you so much, Duncan, first of all, for inviting me to talk on this topic. And so the main, so what we'll talk about today is aging with spinal cord injury with specific focus on the respiratory effects. Um, and I have no conflicts of interest to declare for this talk. So we'll have two main learning goals for this session. One is we'll understand how the spinal cord injury has an impact on the respiratory system, and some of that will include reviewing some of the fundamentals. Secondly, we'll discuss some of the respiratory problems that can occur with a spinal cord injury, with a focus on respiratory tract infections and sleep disorder breathing, which was requested topics, with the focus on diagnosis and treatment. Now, just to kind of start with some of the more fundamental aspect of this talk. So when we think about muscles of respiration, we've got two major groups. First we've got our muscles of inspiration, which includes diaphragm, external intercostal muscles. Then we have our muscles in the neck, the sternocleidomastoid, trapezius, and scalene. Secondly, we've got muscles of expiration, so which includes our abdominal muscles, diaphragm and internal and external intercostals. We've got rectus, transverse, and the oblique muscles as well, which help us with exhalation. And so when we're thinking about inspiration, now the diaphragm is one of the major muscles of inspiration that we consider that as like a primary muscle of inspiration. Now this is supplied by a nerve called a phrenic nerve, which emerges from the cervical spinal cord at the level of C3 to C5. And so during inhalation, diaphragm will contract, it will move caudally, it will displace the abdominal contents, and it will elevate the rib cage, which will help improve the vertical dimensions of our thoracic cavity. Second important muscle group for inspiration is going to be our external intercostal muscles, which is around our rib cage, which works synergistically with the diaphragm. And now this group of muscles are supplied by the thoracic spinal nerves, which emerge from the thoracic cord. And these muscles also help elevate the ribs. So now the diaphragm, as we talked about, is one of the important inspiratory and expiratory muscles. It contributes to about 70% of the inhaled tidal volume, which is the volume of air which we would inhale and exhale at relaxed breathing. It works synergistically with external intercostal muscles to help expand our thoracic cavity. And when we have labored breathing is when we really start to recruit our accessory neck muscles, which helps elevate the upper ribs and sternum. So that's just the fundamental of inspiration. Exhalation is actually more of a quite passive process. So that includes relaxation of our diaphragm. It's really during some of the more active processes that we do, like coughing or exercising. That's when we start to recruit some of our abdominal expiratory muscles. And now those group of muscles are supplied by the thoracic cord. So for anybody who's got a high cervical spinal cord injury or thoracic spinal cord injury, they'll have weakness of those abdominal expiratory muscles, and they'll have a harder time with coughing strength. In addition to reduced cough strength, which can happen with expiratory muscle or abdomen muscle paralysis, you will also see a second effect, which is a reduction with volume of air you're able to pull in with every breath. So typically, our diaphragm is positioned more like a dome shaped. And so when it contracts, it moves downward, and we're able to pull in a very good tidal volume. But when we've got paralysis of our abdominal muscle, muscles, now the diaphragm ends up being mostly like in a flat position. And so now with that kind of ineffective position, it's not able to pull in as much tidal volume. So now this individual who's got weakness of the abdominal muscles, they're going to have to work extra hard and really compensate this by breathing fast to meet their respiratory needs. Now, one of the ways that we can sort of compensate for this and address this is using the abdominal binder when that person is more like an upright position. So what that will do is it will sort of press all the contents in, and it will restore the diaphragm back to its dome shaped, and that will improve the efficiency of inhalation and expiration, and you're able to pull in like a greater tidal volume. And so that's the function of the abdominal binder. So basically, when you've got inspiratory muscle weakness, it will prevent that individual from taking in deep breaths. It can lead to atelectasis, which we call more like a collapse of the distal lung units, and it will impair the gas exchange, and it will result in the lungs being less compliant or more stiff. When we have expiratory muscle dysfunction or impairment, it can weaken the cough. It can have an impact on the secretion clearance. It can increase airway resistance, and that will increase that individual's risk of having infection or such as pneumonia, and it will be more slow to clear. And now this is just some of the data that we have, and I'll present some of the data from some of the studies which I thought were quite informative. So now this is a data from 147 spinal cord injury persons, and they were tracked over a period of 12 years. And what they noticed was that there were common themes. So there were 6 common complications which occurred. Pneumonia being most common in that 12-year period, followed by congestive heart failure, coronary artery disease, urinary infection was common as well, atrial fibrillation. So those were the more common complications which were seen in that 12-year period in this group of above 140 or so spinal cord injury individuals. So as we see this, respiratory complications are common following the injury, but the most vulnerable period really is during the first year after the injury, but the risk does continue to present itself throughout the life. Now, one of the main factors which determines the extent of the respiratory abnormality will be the level of injury, so how much motor sensory level of injury you have, and what is the autonomic neurological impact of that injury as well, which plays a role. Now we'll talk about, 4 different components which are of our breathing system, which are impacted due to the spinal cord injury. So we'll talk about what the lung volumes are doing after the injury and in the follow-up several year period with aging. We'll talk about how the chest and the lung compliance and stiffness evolves over time. And then we'll talk about coughing strength, how to optimize that, and also sleep disordered breathing, or as we call it, sleep apnea. So starting off with the lung volumes, now these are some of the objective lung volume measurements that we measure in the pulmonary function lab by using the devices like the body plethysmography and spirometry. So now with these measurements, you're asking that person to breathe in and out with regular breathing, and that's followed by full inspiration, followed by full exhalation. So by asking that person to do these maneuvers, we're able to objectively capture what is that individual's lung volume. And we're not going to go into the details of what these each measurements mean, but just kind of pointing that after a cervical spinal cord injury, there is a marked drop with these lung volumes. Now, this measure here is something which we measure is called a forced vital capacity. And so this measurement is derived by asking that person to blow out fully as maximally as possible from full inhalation. And this is a very informative measure because it kind of captures a global respiratory muscle strength. So in order to do this maneuver, you need a good inspiratory muscle strength and a good expiratory muscle strength. So it's something that which we look at the initial diagnosis, but also helpful to kind of track over time how this measurement will change. And so as we see here, with the lower level paraplegia, this value is essentially normal. But then as we sort of go up with the spinal cord injury lesions, particularly with the thoracic, high thoracic and C-spine level injury, we see quite a steep decline with this vital capacity. And so what we describe this is a moderate to severe restrictive ventilation impairment. Now, apart from just the level of injury, there's few other factors which has an impact on these objective measures of lung volumes. One of them is a increasing body mass index or increasing body weight. And second is the duration of injury. And so there have been quite a few studies which have looked at how does the lung volume evolve over time and what are some of the other factors which has an impact apart from just the level of injury. And so this was a very good data that came out of a study that looked at about 230 adults with a spinal cord injury. And they were approximately 1 year out from their injury. And so they did notice that there was an effect of duration of injury, and particularly with middle-aged individuals with the tetraplegia. That is, if they had injury for a longer duration, they had a much greater loss with their lung function measurements. And so there were two possible explanations for it. One is, potentially they had frequent respiratory infections, and as a consequence, they had some decrements with the pulmonary function, which they were not able to recover back. Second possibility is the infection was happening, but it was leading to a much larger loss, which was about the same as what would have been lost with the time elapsed since injury. Secondly, smoking had a pretty big impact as well. And so they did notice quite a striking pulmonary function deficit in people who are current smokers, and that loss was felt to be much larger than what we would expect with age and level of injury. So, in summary, there's two common themes. One is longer the duration of injury and smoking. They're two factors which are linked with some of the drops with the lung volumes and incomplete lesions in comparison to the complete lesions, they have lesser degrees of compromise of the lung function objective measures. Now, apart from the motor and sensory impairment, there is an impact of the autonomic nervous system as well, and that plays a role when it comes to respiration. So in tetraplegia and the high thoracic paraplegia, it can have an impact on the autonomic nervous system. Now, the autonomic nervous system, it is fairly diffuse, and so it can have an impact on the airways as well. So when we lose our sympathetic modulation, you essentially end up with a quite high parasympathetic tone, and that has an impact on the airway dynamics. So just to describe that a bit more, and so what happens with that is you end up with more of an obstructive airway physiology. So for instance, in tetraplegia, when you interrupt the sympathetic innervation to the lungs, it can result in an unopposed parasympathetic innervation, which are going to our airways. And so because of that, you may experience bronchoconstriction. And so that can restrict the airflow, especially during expiration. And secondly, it can also increase mucus secretion. So now you have all the airways which are having hypersecretion of the mucus, which is very thick and very harder to clear. Now, this finding of this airway dynamics changing, it is quite unique to the cervical spinal cord injury, and it's not as evident in people who've got lower level paraplegia, like T7 and below. Now moving on to the next topic, which is kind of looking at the chest and the lung compliance and how that evolves over time. So starting off with an acute spinal cord injury, like initially, like in the initial acute phase of the injury, there is generally like this discoordination between our rib cage. So when you've got contraction of the neck muscles, it helps pull up the sternum, it helps expand the upper rib cage. But at the same time, you've got these lower rib cage, which is displacing inward. If someone's got intact diaphragm, it may contract and pull and expand the lower rib cage. but at the same time, there's collapse of the upper rib cage. So you've got this uncoupling of the entire rib cage, and that happens when there is weakness of the intercostal or those muscles which are surrounding the rib cage, and if there is loss of that muscle activity, and if there is increased compliance of the abdominal wall over time and with age, with the chronic spinal cord injury, essentially that sort of a paradox decreases, which is a good thing. And that happens for a few reasons. So first is the rib cage becomes more stiff. There is increased strength is a second reason for the cervical accessory muscles. And also which that leads to a better coupling of the rib cage elements. You can also have a high rib cage stiffness because some of the joints they become more ankylosed, and that happens with the more chronic degree of injury as well. And that happens because if you're breathing at a lower volume or if there's increased spasms of the intercostal muscles. So you've got two consequences. One is over time, rib cage becomes more stiff. And secondly, like the lung compliance also reduces over time as well. So overall, you end up with a quite stiff respiratory system. Now, there's few things which can happen because of that. One is when you have a stiff chest wall, it does require more effort to expand. So breathing becomes more energy consuming. It can increase the work of breathing. Secondly, you've got reduced lung volumes, and that can lead to shallow breathing, which is especially a problem and something which surfaces at nighttime when you have this phenomenon called a hypoventilation, which means you've got like you're pulling in reduced volume with every breath, and that causes the carbon dioxide to build up during sleep. Um, the third consequence of this, the entire system becoming more stiff, is you end up with the poor chest expansion and you're taking in shallow breaths, and that can cause alveolar collapse or the distal lung units to collapse in itself, and which can cause the secretions to pile up there. And also, it can affect the oxygen saturation which can also increase the risk of respiratory tract infections, especially pneumonia. Um, Now, just sort of moving on to the next bit, which is talking about cough and how important it is. And so when we're thinking about cough, it's a very important defense mechanism to prevent respiratory tract infections. And there's we have got three different phases of the cough. So in order to really give a very strong cough, you need a very large inspiratory volume, and that is followed by a compressive phase, and now that is followed by an expulsive expiration, and all of that needs coordination of the intercostal muscles, diaphragm, vocal cord, and abdominal muscles. So for somebody who's got inspiratory muscle weakness, they'll have a harder time pulling in adequate air. Someone who's got expiratory muscle weakness or the abdominal muscle weakness, they'll have a harder time compressing the entire system and forcefully exhaling. And so essentially you end up with a very poor cough, and you're not able to clear your secretions. I would say that the spinal cord injury at most levels to some degree will have an impact on the abdominal muscles, and so the cough strength may not be very strong, and that can create difficulties with clearing the respiratory secretions. Um, the injuries to levels above the T12, they are associated with a decreased cough strength, and that's most likely due to the weakness of the abdominal muscles. Injuries which are below T12, they typically do not have a significant respiratory impairment, and they tend to do well from the cough strength standpoint. Um, Now, when we've got poor cough, there are a few things and consequences which can happen from that. So you have a harder time clearing the airways. So mucus accumulates in the airways. It can cause, we call it mucus plugging. So you've got this retained secretions which are obstructing the airways, and that can have an effect on the oxygen saturation and ventilation. You've got mucus which is plugging the airways, so some of these lung units will collapse. We call it atelectasis. And cumulatively, all of that increases the risk of infection, pneumonia, bronchitis, and it can also have an effect on oxygen saturation and gas exchange as well. So how do we reduce the risk of the respiratory tract infections? I think in order to sort of have an understanding of this, it's important to know what are the risk profiles depending upon the level of injury. So when we're looking at the high cervical spinal cord injury, what these individuals experience is that they've got quite a significant weakness of the inspiratory and expiratory muscles, and the diaphragm is compromised. You've got weakness of the intercostals and the abdominal muscles. And so all of that leads to an ineffective cough. There is an impact on the autonomic nervous system. So you end up with secretions which are more thick and difficult to clear, and airways which are actually producing more mucus. And you've got reduced vital capacity. So these patients are taking very, very shallow breaths. When you're looking at the thoracic and the lumbar spinal cord injury, the diaphragm is intact, but you've got weakness of the intercostal and abdominal muscles, depending upon which level of injury it is. And all of that can reduce the cough strength, but it tends to be less severe than the cervical spinal cord injury. So essentially, the pneumonia risk in these two groups is really driven by a few factors. One is you've got reduced compliance, or you've got more stiffness of the entire respiratory system. You've got ineffective cough. There is hypersecretion of the mucus. And as a consequence, there is insufficient removal of the mucus. And in some cases, there is the risk of aspiration as well in very, very select group of people. And so, what are some of the strategies to mitigate the risk of the respiratory tract infection? So, the key thing is mobilizing secretions. Now, this is important to prevent atelectasis or those collapse of those distal lung units and to prevent respiratory infections. And now there's few different strategies that we can follow to mobilize the secretions. One is something that we call manual cough assist, and we'll talk about that a bit more. And that's typically done when someone is sick up to every 4 hours to every 6 hours. You could do percussive therapy, so like a chest physiotherapy. Hydration is key. And so hydration can help ensure that the mucus is not very thick, which makes it a bit more easy to clear. And you've got some adjuncts like the pharmacotherapies that we use, like the nebulizer treatments, like with Ventolin or the salbutamol, which is a bronchodilator, which helps open up the airways. You could use N-acetylcysteine, you could use saline nebulizers. All of these sort of adjunctive therapies help with the mobilizing the secretions by making it less thick, and so it's much more easy for someone to clear that out. There's also a machine called a mechanical insufflation and exsufflation, and then so we will talk about that as well. It's important to avoid using that machine if you've got the concurrent, like a pneumothorax, which is collapse of the lung, or if you've got very severe emphysema. It's important to get some directions from your medical doctor. Second, ventilation support's really important as well. Importantly, you want to avoid, and treat chronic hypoventilation. So by hypoventilation means you've got high carbon dioxide value. And it's been shown that anyone who's got a high chronically elevated carbon dioxide, they're more likely to have complications from hospital stays, and they're more likely to have hospitalizations if they become sick with pneumonia, because there is very minimal reserve before which they can tip over the edge. So early recognition of this nighttime hypoventilation is quite essential. Aspiration risk also needs to be addressed, and so that could be through a formal swallow evaluation if you felt that the food is getting stuck in your mouth, or if you've experienced coughing after a meal. Making sure like you're in upright position during feeds, and the texture modification, and really having a very good oral hygiene. All of that can help reduce that risk of aspiration resulting in a pneumonia and infections. So now we'll talk about how do we increase the cough strength, as we recognize like this is one of the key strategies which can help reduce the risk of pneumonia. So there's two ways that we can proceed with this. One is you can assist inspiratory phase of the cough, and second is you can assist the expiratory phase of the cough. Normally, it's been shown that for people who assist both phases of the cough, it has a better impact in improving the cough strength. And so now there's few strategies that we can use for assisting the inspiratory phase of cough. One is by using a bagger or like a bag mask, which comes with a one-way valve. And so through that, you can do breath stacking of 2 to 3 breaths. You could use glossopharyngeal breathing, or you could use mouthpiece ventilator if you've got one. And so all of that helps inflate the lungs before you try to exhale out or forcefully exhale. You could also assist the expiratory phase of cough by doing a manually assisted cough techniques if needed, especially helpful if you've got abdominal muscle weakness. And so what it does, it essentially will increase the abdominal pressure, which pushes up the diaphragm. And so that gives you more force as you're trying to clear the airways. You could also use a mechanical insufflation, exsufflation machine as well. And so, how often do we do these sessions? Typically, these sessions are done twice daily or up to 4 to 5 times a day if you are sick with pneumonia. It's better to do it before a meal or wait at least 1 to 2 hours after a meal, and also good idea to do this before bedtime. You can combine the lung volume recruitment followed with an assisted cough 2 times daily. If you were to do these sessions, space them out by at minimum 10 minutes because you don't want to overventilate and create hyperventilation where you are really dropping your carbon dioxide. So important to space that out by at least 10 minutes, if not longer. And now this is the machine, it's called a cough assist machine. It's a mechanical, non-invasive airway clearance machine. And so what it does is that essentially it provides a positive inspiratory pressure, which is similar to taking a very deep breath in, but at a much higher pressure. And that is followed by a very rapid shift to a negative pressure. And so the airflow changes that happen with this swings of the pressure sort of simulates the normal coughing mechanism that we have. And so you can deliver this by either a mouthpiece, you can use a mask, or via a tracheostomy tube. So this cough assist machine can be quite helpful, particularly in people who've got a very severe weakness of both inspiratory and expiratory muscle groups. And so the way it works is that essentially it will alternate with a positive swing in the pressure. There is a very brief inspiratory hold, and this is followed by a very rapid negative exsufflation pressure. And then you've got a few seconds of hold, and this repeats itself. So this is almost like having a cough back to back, back to back. And you can also add some other features to that as well. And now lastly, we'll talk about sleep disordered breathing. And so now the sleep difficulties are quite common in this group. And so there was a survey that was done which included about 1,500 people with a spinal cord injury. And what they noted was that the sleep problem was among the top 5 most common secondary health conditions and the second most likely to go untreated. And so were 2/3 of the people had reported having poor sleep quality. Now there's few factors which can disrupt the sleep in this group. So some of the things can be pain, bladder routines, sleep habits, and if you've got underlying sleep apnea or insomnia or restless legs, all of that can contribute to the sleep difficulties in this group. Um, I'll focus a bit upon on the sleep apnea. And so now the sleep apnea or sleep distorted breathing, it really includes or encompasses several conditions. And all of that, the common theme is there's abnormal breathing during sleep. And that leads to a poor sleep quality, and it can make that individual feel very sleepy and tired during the daytime or after they wake up. There's a different types of sleep apneas. So you've got obstructive sleep apnea, central sleep apnea, and sleep-related hypoventilation. These are the more common types of sleep apneas that we see post-spinal cord injury. Now, when we're talking about obstructive sleep apnea and central sleep apnea, what that means is that there is a complete cessation of the airflow or reduction of the airflow, and that leads to oxygen desaturation and sleep fragmentation. Both of these entities are different though. So for obstructive sleep apnea, you've got closure of the upper airway, but the ventilation drive from our brain to our lungs is intact. with the central sleep apnea, the upper airway is open, but the respiratory events happen because there is either a reduced or absent breathing drive. And the hypoventilation is during the periods of sleep when you've got reduced ventilation, so like reduced tidal volume, and that causes a steady rise with the carbon dioxide value. So there are three different entities, and they have different physiology. And so the level of the spinal cord injury does have an impact on how prevalent is sleep apnea. So with the tetraplegia, they're more likely to have sleep apnea than those individuals with paraplegia. Now the prevalence can be as high as 83% in the first year following injury. And now, as we move on to the chronic injury, that range can be 27% to 77%. There's quite high prevalence of sleep apnea with the cervical injury than the thoracic spinal cord injury, so 93% versus 55%. For people who have lower level paraplegia, there does not appear to be a significant difference with the prevalence of OSA in comparison to the general population. This was a very interesting, data which came out, which looked at a group of people who had T1 and above sleep apnea, and like the question they had was, how soon after the injury do we start to see sleep apnea? Is it many weeks later, many months later? At what time period do we start to see sleep apnea? And so what they did was they had done a sleep study for people who had T1 and above spinal cord injury at 2 weeks, 4 weeks, 13, 26, and 52 weeks post-injury. So essentially, we start to see sleep apnea as early as 2 weeks post-injury. And the prevalence of this does peak at 83% at 3 months. And after 6 months, we start to see reduced incidence of the sleep apnea, but much of this was based upon what changes happened with their abdominal girth, and that had a big impact on how likely a person was to experience or have sleep apnea. Now, this is demonstrating what percentage of people had mild, moderate, and severe sleep apnea. So this is highlighting the percentage of people who had severe sleep apnea at 2 weeks, 4 weeks, and 13 and 6 months post. And so we start to see that the degree of sleep apnea, or the percentage of people who had severe sleep apnea, does decrease in the second 6 month post injury, but that's not for everybody. So for someone who has experienced a pretty large increase with the waist circumference, the AHI score does continue to remain high, or which is a sleep apnea severity score. Now, what are the mechanisms of sleep apnea in the spinal cord injury? And so when we're looking at two different groups, which is the cervical and thoracic, and this is the data from about 26 people. And so majority of these individuals did have sleep apnea, so 77% of them. But interestingly, what we see is that when you have cervical spinal cord injury, many of them actually experienced central apnea. That is, they've got this diminished breathing drive rather than the upper airway obstructing during sleep. Whereas with the thoracic cord injury, we didn't see a high percentage of them having a central sleep apnea. And so like the pattern of sleep apnea that we see will differ. So with the thoracic injuries, we see a more of a garden variety of sleep apnea, which is obstructive or central apnea. But with the cervical injury, like the mechanism tends to be more centrally mediated. That is, when they go into sleep, there is either a diminished or absent breathing drive, which is triggering some of these respiratory sleep events. Now, what happens if you've got sleep apnea in the context of spinal cord injury, and what are some of the benefits of treating this? So again, this was a study which looked at treating people who had moderate to severe sleep apnea, and they were treated with a machine called a CPAP machine for 4 months. And this included about 33 individuals who had cervical or thoracic level injuries. And what they demonstrated was that in this group of people, they did mention improvement with the daytime sleepiness, sleep quality, fatigue, and quality of life was significantly improved with the CPAP therapy. And when they interviewed these group of people separately, majority of the participants confirmed that the CPAP therapy had a pretty beneficial impact on their mental health and cognition after a 4-month therapy. And so likely these benefits would be perceived later on post the 4-month period as well. And there have been quite a few data which have, interviewed to learn from some of the more living experiences with the CPAP therapy. And so more common theme tends to be after using the CPAP machine for treating the sleep apnea, they feel less tired, feeling more restful. It's made a big difference. It was a very positive change which happened by using this machine. Another participant had mentioned, now I'm the first one to and the first preacher to tell people to consult when I hear symptoms such as this one. Some of the constraints though was that it's an extra machine that you're carrying with you, and then some people who had mentioned difficulty with coordination of the airflow with the CPAP machine. And so the impact of the treatment for the sleep apnea is more common themes have been it can improve sleepiness, it can improve fatigue, it can potentially improve the cognition as well, but that's been less clearly studied. And it can maybe have an impact on the cardiovascular outcomes, though specifically with the spinal cord injury, it's not been separately well studied, but we can extrapolate from the information that we have from other population. And so, as we look back at some of the more common complications which were highlighted over a 12-year period, cardiovascular disease was one of them. So, over a 12-year period, congestive heart failure, coronary artery disease, atrial fibrillation were some of the top complications that happened over a 12-year period. So, it would be of interest to reduce that risk as well. And so when we look at the data of whether treating the OSA with the CPAP, whether or not this will help reduce that risk. And so this is the recent data that came out, which looked at about 3,000 people with OSA and pre-existing cardiac disease. And they had pulled all of these people together from 3 previous trials. And so half of them were using the CPAP machine and the other half were not. And they were followed for a period of 3 years. And interestingly, what they had noticed was that for people who had very high risk markers, so that is when they go to sleep, they've got a very marked drop in the oxygen values and they've got very high increase in heart rate. There was a significant reduction with the cardiac disease and cerebrovascular disease after using a CPAP therapy. And so how do we investigate for sleep apnea? So there are 2 possible options. One, you could do an in-clinic sleep study called a polysomnogram. Secondly, you could do home-based studies. We call it level 3 studies or home sleep apnea assessment test, or overnight oximetries. So now some of the more common symptoms which can happen with sleep apnea is loud snoring, choking, gasping. You wake up feeling unrefreshed. You've got morning headaches and daytime fatigue and excessive daytime sleepiness. Having said that, these questionnaires and like these questions that we often ask, they're not always very predictive of what we will find when we actually investigate that individual. So there has been a lot of studies which have looked at how accurate are these common questionnaires that we use in detecting sleep apnea in people who've got spinal cord injury. And as it turns out, they're not sufficient to rule out sleep apnea. And so if there is a suspicion, the best is to test it further. And so I'll share some information about some of the home-based sleep apnea tools. So now the polysomnogram, I'll say, which is done in the pulmonary function lab, it is a gold standard for diagnosing sleep apnea because you've got extensive monitoring. You're tracking that individual's sleep. You're tracking whether or not they're snoring, airflow, EKG. It's a very, very thorough monitoring process. But understandably, it's not always possible for everybody to come in for a sleep study. And so the alternative option could be a simple tool called an overnight oximetry. And so this entails placing in on your finger in an overnight oximeter probe, which is tracking the oxygen saturation and the heart rate. And then we end up with this tracing, which we look at, and that provides us very helpful clues about how that individual's oxygen is doing. And from that, we can make an interpretation of whether or not that person's got sleep apnea. And so how accurate is this? So for if your pretest suspicion of that person having moderate to severe sleep apnea is very high, then you have about 90% chance of capturing that. But it's not enough to rule out sleep apnea. So you will miss some mild to moderate cases. So about 20% of the people with moderate to severe sleep apnea could be missed with simply the overnight oximetry tool. So it's a great tool for screening, but it's not enough to rule it out. So this oximetry probe, it does help screening people who've got moderate to severe cases, but it cannot rule out milder cases. And also it cannot differentiate between central and obstructive sleep apnea. Our second tool is our home sleep apnea study. And so this now includes more monitors. So it includes airflow monitors, breathing effort belts, which goes around your abdomen and your chest. You've got a pulse oximeter, and also it will track the body position. So you can see whether or not someone's got sleep apnea on their back versus their side position. And having said that, this also has a bit of a drawbacks. It's more informative than the overnight oximetry, and it does provide some like respiratory data, like apnea, hypopnea index. It gives idea of what is their drops of oxygen saturation, how frequently is it happening, but it can underestimate the severity of sleep apnea as well. And so it can be used, like some of these old home tools can be used as an alternative to the polysomnogram, provided that there is a high pretest suspicion of that person having moderate to severe sleep apnea. So if someone's got symptoms, you've done the home studies, and if they're not informative, then typically we would recommend getting a polysomnogram to rule it out more conclusively. Next, we'll talk about CPAP and BiPAP. And so both of these machines are different. And so like the CPAP, it provides continuous air pressure throughout inhalation and exhalation. With the BiPAP, you've got different air pressure. So you've got different higher pressure during the inspiratory phase and a lower pressure during expiratory phase. And so because of this pressure difference, it helps increase the volume and the minute ventilation. And there are different modes to keep in mind. So like the CPAP is mostly used for treating for someone who's got strictly obstructive sleep apnea. And some cases of central sleep apnea can also be treated with the CPAP machine. With the BiPAP, we will see different modes being used. So there is BiPAP S mode, which means there is no backup rate. So if that person's not making any effort to inhale the breath in from the machine, there is no backup rate. There is a BiPAP ST mode, which comes with a backup rate. So if that individual fails to make a breathing effort at nighttime, then the machine provides the breath. So there are different modes and there are more better algorithms available with the BiPAP. CPAP is very effective for treating obstructive sleep apnea. Now, the sleep apnea, even though it is great to treat it, there are some challenges with getting used to this machine, and there have been some data which have shown that the early experience of the CPAP really dictates how that individual is going to do after many months. And so the mask comfort, I think, is one of the key factors which has a big influence on that individual being able to use the machine. And so I'll kind of share some pictures about the different mask interfaces that we have available. So you've got a oronasal mask, which is a full face mask. You've got a hybrid mask, and this is a nasal pillow mask. We call it a nasal cushion mask. And you've got a nasal mask, which covers the entire nose. And so there are some pros and cons for each of these mask interfaces. So with the nasal pillow mask, it essentially fits the nostril. So it's a good option for someone who's got claustrophobia with a larger mask. They want to wear glasses. They've got facial hair, which interferes with the other mask interfaces. Nasal mask is a good option for someone who's frequently changing body positions or if they're needing a very high pressure setting. Full face mask can be an option as it covers the entire nose and the mouth. So it's a good option for someone who's oral breathing at nighttime or if they've got nasal congestion or blockage. At the same time, if someone's got oral breathing, there is an option of adding in a chin strap with a nasal mask interface, and which is quite effective in controlling the mouth leak. So conventionally, it was believed that the full face mask is a pretty equal choice to the nasal cushion or the nasal pillow, but there have been a lot of studies and data now which have shown that the nasal mask is actually more superior than the full face mask in treating sleep apnea. And with the nasal mask, we're able to treat the sleep apnea with the less high pressure requirement. So our go-to mask generally tends to be a nasal mask. And so there are a few things to consider for the mask selection. One is, what is your individual preference? What is a person's facial anatomy? Whether or not they've got facial hair, which can affect the leak. If there is history of claustrophobia, whether they've got significant nasal congestion, oral breathing, if they've got septal deviation, in which case you would prefer a oronasal mask. And so all of these things are sort of considered when we think about the mask interface selection. Now there was this research project, I'll kind of end with that, which looked at the CPAP treatment for quadriplegia individuals, and what they had mentioned was that the best results for 4-hour CPAP tolerance was obtained by using a nasal pillow mask with or without the chin strap for the first night. And in order to improve your comfort with the PAP device, frequently visiting the CPAP educator, especially during the first 2 weeks of starting this machine, tends to be key in helping you adapt better to the machine. And so I'll kind of end with that. And now some of the key take-home points. So as we know, with the spinal cord injury, it can have an effect on the respiratory health. The level and completeness of the injury determines how severe is the impact. And the injuries, especially with the cervical and the upper thoracic, can result in significant weakness of the inspiratory and expiratory respiratory muscles. The common complications we had talked about is pneumonia, sleep apnea, reduced cough strength, which can all predispose to the mucus impaction. And prevention is key here. So screening for sleep apnea, reducing the risk of frequent respiratory tract infections. So that can be with assessment of aspiration risk, vaccination, ventilation support. All of that can help mitigate that risk. So I will end with that and see if anybody has any questions.
Thank you, Aditi. That was very, very thorough. And I wrote down a couple of questions. I'm going to ask one though that I think is really important, and it's not for necessarily this group because our group's a little older, but exercise over time. Is that helpful, and does that affect respiratory health?
Yes, yeah, absolutely. So by exercise, do you mean specifically like the muscle training, like the respiratory muscle training? Is that what you implied, Duncan?
No, no, I just mean exercise like playing wheelchair basketball or going for a wheel or going to a gym and doing cardiovascular work. Any
Oh,
of that kind of
yes.
stuff.
Yes, yes, yeah, absolutely. So I think all of that has a very positive impact as well. And so, even though like we talk about something where which I talked about the whole stiffness of the entire like breathing system, all of that is going to be less if you're more active, because when you exercise, you are taking in, bigger breaths. And also it has a positive impact on the cardiovascular risk profile as well. So yes, it has a very positive impact. Yeah.
Yeah, I was just I had been talking many years ago to a peer who was an opera singer before he had a spinal injury in the cervical area. But anyway, he ended up going back to the breathing exercises that he used as an opera singer, and he found that there was an incredible increase in his breathing capacity. Is that something that everybody can do? I don't know what those exercises are. I'm not an opera singer, but anyway,
Yeah. Yeah, so I can't speak to the opera singer part of it, but I would imagine that it would include using like your diaphragm muscles quite a bit. So I think it depends upon the level of injury. So and like how complete is that injury? So if you've got some innervation of the nerve to that muscle, if you were to exercise that muscle, it is more likely to become stronger. Versus if you've got complete disconnection from the nerve to the muscle, then that exercise may not be possible. But I think, if you've got some nerve connection to that muscle is going to contract, and more you work it, more stronger it's going to become. Yeah.
In the presentation, you talked about the levels of injury and the access to musculature for respiration.
Yeah.
And I wanted to know if there was like partial access to some things like abdominal muscles if you have a cervical injury, and can that be improved?
So that is a bit whether or not it can be improved over time, that is a bit hard to tell. And whether or not like the research has shown that if you do specific exercises, will that lead to more improvement? That's but not very clear. But if you've got incomplete level of injury, technically, yes, you could have some degree of preserved abdominal muscles. You could have that. Yeah. So it kind of depends upon whether it's complete or incomplete lesions. Within the incomplete lesions, I feel like there's also quite a big spectrum as well.
I have a comment.
Oh, go ahead.
I My name is Jacques, and Duncan knows me. I have a paralyzed tongue to complicate matters, and I have a lot of pain during the night. And I find that the choice of mask is absolutely crucial. I've gone to 3 or 4 different types, and there's one that I've just started trying that has the air connection is not in the front of the mask, it's at the top of the head. So that when you thrash around in your sleep in pain, it's not disconnecting anything. So I would say to people, really experiment with different types of masks if you're going to use a BiPAP or a CPAP machine.
Yeah, absolutely. I feel like the mask comfort is key, and I find that more you try it out, when you go to the vendor, they can really help you find something which works best for you. So for sure, yeah.
I have one more. Early on again in the presentation, you said that sleep apnea is prevalent, especially in cervical injuries, in like up to 83%.
Mm.
But at the same time, it's the second most untreated. Do you have a reason, do you think, for that, or?
So yeah, so it's not I wouldn't say like the sleep apnea is the second most untreated. So it was more like the sleep difficulties were the second most untreated. And so
Yeah.
within the sleep difficulties, it would be insomnia, restless legs, it would be sleep schedule dysregulation. So it was not the sleep apnea was specifically the second most untreated. It would be the entire sleep difficulties was the second most untreated. Yeah.
And do you have I'm just looking to see if there's a reason for that or if that could be improved by doing something.
Yeah, so I think like in general, just more awareness and information sessions that we're having, I think that could be very impactful. I find that the initial point of screening is, happens in the hospital, it happens like in the rehab center, and then it's not followed up afterwards. So I think having a regular follow-up with the GP and for them to be informed that there is this concept of sleep apnea and that it is common, I think that's essential. Yeah.
Okay, Sandra, you have your hand up. Go ahead.
I don't know that I necessarily have a question per se, but as I'm getting older, my spasms are getting way worse and they're like full body spasms. But the hardest part is when my ribs contract and I can't breathe because everything is just so tight and stiff. I've almost gone to the point where I've just about passed out sometimes because of the spasm being so tight and holding my breath for so long. Do you think exercise would help with this versus just focusing more on my breathing? Because I tend to hold my breath a lot too, because I forget to breathe.
Yeah, so I don't think the exercise specifically will address the spasm. I mean, I think it will have a positive impact in the other domains, but it may not get rid of the spasm per se. Generally I would say like the spasms, it's not as it's not managed by the respirologist, so I may not have a very good answer for you in that. I've seen that the physiatry team is they do a very good job in addressing spasms and making some like recommendations for that. Yeah.
Okay.
Thank you.
Scott?
Yeah, I was wondering about follow-up after a test. I've had a one of the tests where you take it home and you wire yourself up and everything, and they found that I do have sleep apnea. Well, it's actually central sleep apnea, and I'm pretty sure it's the pain meds that I'm on and things like that. But they found that I don't know what those numbers mean, but 5 to 8 times or whatever. So it's not necessary for me to be treated, I guess, or to use the CPAP. What do people follow up, or should there be a follow up years later, say after something like that, to make sure things are still the way they are, or getting worse, or what?
Yeah. So like I do think it does need a follow up at least a few years later. And so that would be, so if you've got a mild sleep apnea that was captured with the home study, like I'd mentioned, it can sometimes underestimate the severity of sleep apnea. So I would, in those cases, recommend referral to the sleep lab, where they do a in-lab polysomnogram which is a more gold standard and gives a more accurate assessment of the sleep apnea. So we typically do see referrals where mild sleep apnea is captured with the home study. But as we know, it has some drawbacks. It's not fully conclusive. And then we do an in-lab study to be absolutely sure. Follow-up, if that in-lab study is also demonstrating mild sleep apnea, a follow-up study is recommended if you've got change with your health. So if you've got, new medical conditions, which has an impact on the nighttime breathing, if you have had a change of medications, which has an impact on the nighttime breathing, or if there's been change with the body weight, or if there's change of the symptoms, like you're waking up more tired, fatigued, and there's no other explanation for it, then we'd recommend a follow-up. Yeah.
Follow-up question to
Oh,
that for those that live in more remote areas in BC. I'm in Victoria, so it's more
Okay.
central. But for those living in more remote areas, where do those are those sleep centers where you can have an in-house evaluation? Do you have to come to one of the larger urban areas? I guess is my question.
Yeah. So unfortunately, for the in-lab or like in-lab gold standard polysomnogram, it has to be done in one of the bigger centers, where they have a sleep lab, and which would be in like one of the bigger cities. Yeah.
so can you kind of tell us where those are? Like I don't know what a bigger city is. So Vancouver, Victoria, Kelowna, I'm not sure.
Yeah, so from what I know, yeah, so obviously Vancouver, we have quite a bit of them. So we have the Abbotsford has it. I believe Burnaby has one as well. Surrey Hospital has it. Vancouver UBC Clinic. And Victoria has one. Nanaimo, Kelowna, Kamloops. They both have sleep labs. Um, and I so those are the main cities that like which do have a sleep lab. Yeah.
What about up north, say Courtney or Prince George?
I don't think they have a sleep labs there. Good point. Yeah, they don't have a sleep labs there. No.
Okay.
Yeah.
Just wanted to because the people that are online here are from all over the province.
Yeah, absolutely. Absolutely. Yeah.
Okay.
Yeah, I
I
just wanted to ask
think
about the vaccine support and whether, like, I've had the Prevnar, but whether you recommend RSV as well.
Yeah, I do recommend RSV. So it's approved for people, I believe, over the age of 70 or 75. So it has been shown to reduce like the severity of the RSV viral pneumonia. So I do recommend that routinely. I do. Yeah.
Okay, thank you.
Okay, Sandra's got her hand up again.
I don't know about the sleep lab that you're talking about, but I know Williams Lake has a sleep place that you can go, and I believe you can go and get the overnight testing, go into their thing, sleep there overnight and stuff. So
Okay.
Oh, it's good to know.
Okay.
But I want to thank Aditi because this was great. You did a great job. All right. Thank you, Aditi.
Thank you. Thanks for having me.
Thank
Yeah,
you.
thanks.
Bye,
Thank
everyone.
you.